Exactly. 1, 2, 3. Action, please.
So the topic today is about dehydration, or how to decrease dehydration in patients who's having defunctioning low ileostomy in rectal cancer. But before that, I have to present myself. My name is Eihab. I'm a surgical resident. So I'm working my way to be a surgeon. So those people, Pamela, Marie-Louise, Henry, Hanley, my supervisor, and then my sub-supervisors, they are from the colorectal team, surgery colorectal team in the hospital. So before, I thought that, I'm not sure if I'm cheating or not, but I thought that to break my presentation to two parts, today I'll just start with the background and why I'm researching this. So I'll talk more about the disease. And then next time we'll talk about the research itself. Yeah, I think it's fine. Good. So as we said, it's about rectal cancer. And I took this picture from YouTube. I should put the resource, but I didn't. So this is the cancer. Theoretically, if this is the rectum, and this is a sagittal view of the rectum, you have, the rectum is about 15 to 20 centimeter, and it's divided to three parts. 3/3. So if the cancer is in the upper and middle third, you have to take it out with what's called partial meso. Meso is the perirectal flap and rectal excision. So what you should do, that you will take the disease part and all the surrounding tissues. And what happened then, you come and you connect the colon and with the what's rest of the rectum, and you make the colorectal anastomosis. The thing is that, okay, you can connect it together, but what if it was leaked? And the leakage means that it would leak some fluid out of it. And the problem with that is that it happens, and it happens like, it happens from 10 to 20%, and this problem has to be operated, so the patient will suffer a lot. And then they come up with a solution that if we divert the bowel content with small bowel or local ileostomy, we will decrease the leakage percentage. So this is the theory, but it's always in the research field will ask, what's your evidence, right? Because this is a new. It was a new intervention. So in 2007, a group from Örebro University have done this clinical randomized multicentric trial where they had, it was situated in 21 different hospitals, and they collected around 234 patients, divided two arms. So I will just summarize the research. So all the patient has a rectal cancer. All the patient has to be operated, but then you have two options for operation. You have, if we get back, you have just to connect. You have just to connect the healthy part, and the other group connected the healthy part and did the ileostomy. So we want to see which one gave the benefit of not having leakage, and the result was that when the patient had a local ileostomy, they had 3 times less symptomatic and stomatic leakage than the other group. And when the patient has local ileostomy, they needed 3 times less urgent abdominal reoperation. That means they will go to the operation room again. So that was statistically significant. So since then, since the 2007, it was like a standard in the medical field that all the patients who's having rectal cancer and doing this operation, they will have a local ileostomy. But with every intervention, someone from back of the room will come and tell us, okay, what's the risk? What's the downside? You didn't tell us. And then came the colorectal team in 2012, and they reviewed what are the risks related to this diverting local ileostomy in this group, specific group. And they come with a simple table. They divided the complication to 2, minor complication and major complication. the minor complication, as we remember that I didn't point it out, but this is the ileostomy, and this is how it looks. And a minor complication, we can have some bowel content outside in the skin, and then if we had it around the skin, we will have irritation. But okay, just a minute, yeah. The major complication is about dehydration, obstruction, and others. And 20% of those patients will have a permanent, will have a stoma for life. So it shouldn't be just temporary, but now 20% of those patients unplanned, they will have a stoma, a permanent stoma. But my research is about dehydration because it's the higher, the more relevant or most common complication those patients have, about 30%. So the question is how to prevent or decrease dehydration in those patients, and this will take it next time, or Pia will let me continue. So thank you.
Thank you very much. We're starting like this, but I didn't turn off the electricity, but it was 1 minute. Yeah, maybe you missed the 1 minute warning.
Yeah.
Yeah. Okay, just keep your presentation up. Yeah, because we can look at slides and discuss if we need to.
Sure.
You can also put it on slide sorter so we can see all the slides if you can.
Sure. Slide sorter.
Which is if you show all your slides so we can decide on which one we want to discuss.
This one.
Yeah. Now there's no signal. Did you take out the?
Should I take that?
It was there. I just did
Move forward and it obeyed me.
so
It's a little bit,
yeah. You have to,
Yeah.
All signals.
they want to be just in the right spot. Give
Can
it
you
a
adjust
tap
it a
and
little
wiggle
bit?
it.
Yeah. Give it a toss. It's very strange.
Technology challenge.
I was like, it's all the technology.
Exactly. Exactly.
Okay.
Then
When
you
I
don't stay here.
when I can do it like this. Aha. So it.
It's searching when you.
No, it doesn't.
Is it the screen?
When I put it in the presenting mode, it
Yeah.
comes. But
Oh,
once I get out, I think because I put it in the use presenter view. Let's see.
I think it's okay if you put it in the presenter view. There's not that many pictures.
No, it doesn't.
Leave it like that. It's okay, we can move forward. Okay then, you start, Eihab.
Okay.
Any comments?
Yeah.
Yeah.
I think our challenge, my challenges was that we did introduce ourselves. We know a little bit about ourselves, but I wasn't sure what's my audience. Where should I start? What should I elaborate more? What should I come back? And it was challenging for
That's
me.
a challenge here. You don't know so much about this target
No.
group. Yeah.
No.
Okay.
Technology, no, it wasn't. But I think everybody was, maybe because I started first, so everybody is awake, so that's an advantage.
Yeah.
Everybody was paying attention, so that's what's good.
Is there anything in specific you want feedback on or feed forward on?
Yeah, I got back to the slides many times, and I'm not sure if that's annoying or not. I felt I'm comfortable to you because we're a small group and
Yeah.
we can be frank to each other. So I just thought about, because when you're presenting to the audience, you're tasked just to get rid of it and
Yeah.
just to give it, and whatever happened afterward, if they understand it or not, it doesn't matter. But I thought that no, I want them to follow up, so
Yeah.
that's why I did that.
And I also want to make clear, I didn't do that before, that we don't take questions now this time because it will take too long today on Monday. But on Friday you also have a session with questions, of course, on content. But today we focus on feedback only. Mm? Okay then, so shall we let them
Of course.
start, please? Anyone? Go on.
I thought it was actually a good thing that you went back to the slides we explained, Nick, because to us that aren't as familiar with the concepts and the operations, it might have been confusing if you just mentioned the name of the surgery. So for this audience, I think it was good to go back and show us again this procedure and this procedure. So I didn't find it annoying.
Thank you.
Megan.
Just to add on that, I agree, but I think if you have to do it often, and it's like a couple slides back, I feel like a lot of professors, when they have that, they just put the slide again, like duplicate it next, so at least it's not as much of a, he's where to go, oh, okay, he's there, so. But I do think it's very helpful that if you need to reference it back, that you do, because that helps for the presentation.
Joe,
Can I-
please. Yeah.
Yeah, I agree. I think you mastered the subjects. I just got a bit overwhelmed in the slide where you showed the table, and you just mentioned like the results in one column.
Yeah.
I think since you're not talking about the rest, maybe I think it would be easier for me just to follow that part of the table and like.
I really
Can you show
take
that
out
slide?
the-
Can you show that slide? I have, but it's easier to talk about something you see.
There, because I think you only mentioned the first column.
This one. So
Yeah.
I shouldn't take this.
Yeah,
with
I
me.
think it was a lot of text, and I tried to
Distracting.
follow, and then I didn't actually understood the
You're
part.
right.
Or if you like highlight what you want
Yeah,
people
or
to,
that.
you don't have to like crop it, but
Yeah, yeah. I mean, that's
I like
right.
to just put boxes around
Or
it.
that.
Yeah. That's what.
And if you come back here, I have just to take a look. Sometimes it's a good
Okay.
thing. Yeah.
It's small.
So yeah. So you see the font sizes.
Yeah.
Yeah.
It's very small.
I can see it, but it's really small for me down here. That's something to think about, and we will discuss what is an ideal font size, or how far
Yeah.
can you go when you make them small.
Exactly.
So it has to be with the design of the slide to think about how much can you put into a slide
Yeah.
and still keep
The
up
content.
yeah.
Okay.
More things. You can stay here, you can walk up again. I just wanted to show you because it's easier. Please, what else?
Well, I thought it was good, even though I'm in a similar field. I would, the fact that you used not just medical terms for so that people would understand.
Okay.
Yeah, that you adjusted
Mm.
actually. So that I think that's good. And a bit on the same note, I think seeing it was dehydration, that is what you will continue on Friday. Maybe that should stand out or be marked as well a bit. Because I think that at least 20% is not the most important.
Mm.
Yeah.
You're right.
It's the reason why you're like there is a discussion, but it's not. It's very big for it.
Yeah.
Sometimes,
Yeah.
sometimes when you have a table from the paper, maybe you can do by yourself in the PowerPoints and make it clear with a bigger, yeah.
I think it was also, for me it was too much detail actually.
So you're talking in a hall, in the
Yeah.
hall presentation.
Yeah.
Okay. Was I too fast? Jumping from slide to slide?
No, it was okay to jump,
Okay.
but it was for me too much detail, so the idea or the main idea is like distracted, how
I understand.
confused sometimes.
I really liked listening to you because you were super calm and you were very aware of getting the crowd to understand your field. So I liked it a lot, even if I'm not within this field.
And I have to disagree with about too much detail because I think I would actually I wanted you maybe to explain why there is a leakage in the anastomosis because that's a failure of the. And I don't think everyone would understand that.
Not the surgeon failure.
Yeah, no, I absolutely no, but I'm just saying like it wasn't
Yeah,
enough,
yeah.
it wasn't enough detail. Not that
Yeah.
there was too because
Yeah.
because you got the feedback that there was a lot of detail And I think it's very difficult to understand why you would do a stoma when you've done, because otherwise, like a stoma, you do when you don't have an anastomosis. So,
Yeah.
but in this case, you're trying to save the anastomosis by putting a stoma. So that's a very like big. You don't do this always.
No.
That's, yeah.
But I think this is a variation in the target audience.
Yeah, no, absolutely. But that's why I mean, like, I think if
Good,
you had even
yeah.
less, then you wouldn't understand.
Lose interest, yeah.
Yeah.
Sure, maybe focus on the details of the background, and maybe to us it's not that relevant to know exactly what publication or what group found.
Yeah, you're right.
More
Just talk about the process.
the background facts so that you get the audience on board.
Yeah.
Christina? And then-
I like it, yeah, I'm coming from a completely different field, but already the first slide, I got an idea what this whole presentation will be about, because you visualize already what you will talk about, so this I really enjoyed.
Thank you.
Anything else? Good. Do you have any advice on how to work on the balance between? Because now you don't know so much about the target group, except that you're all PhD students at the Faculty of Medicine here. But any idea of how to plan when you don't really know? How can you think when you do a presentation, 5-minute presentation, to get the right details?
Christina.
Yeah, maybe you will have the presentation to someone already beforehand who is not in this field,
Yeah.
and ask him or her, she or he understands.
You know, like
One more practical.
I'm not working on this field, so at the beginning it's very difficult to understand too. And also, but one thing is very good is you know how you want to say, and when you look back, and then you have a clean mind to switch on back.
To focus
Yeah,
on.
so it's good, and also you can show the time so you could, just 6 minutes or more, but it's fine. So the time also really serious. Also, when you give the presentation, you have to think about the time. Otherwise, the listen to you like annoying always you go so long. So I think it's good. Can show the time is good. And yeah, but for comment about how lot feedback for this. The time and you have to remind us.
Okay, thank you, Lily.
Something that I've experienced is that when you are to hold a talk to a different target audience than your sort of normal one, usually a target audience that is less into the topic, you use like a presentation that you've used before, but to a different target audience, and you try to scale it down, and it's really hard because you want to show all this, it's your work, it's and you think it's important. Sometimes I found it easier to construct a new presentation because then I can just choose what I want to put in, and that's not as hard as taking out stuff that I still think is really important.
I think you have a point there,
That's
Johan.
very
Because I think one way of working is to start with what is my main message? What do I really want them to understand about my presentation? What is the take-home message or the essence of this presentation? So if you can formulate that in 1 or 2 sentences, then you try to think about each slide. How does this slide contribute to this main message? So what is the message of this slide? And it connects to this. So it's a sort of alignment. Yeah. So, and then I agree with you, and it's easier to build up than to take out. So if you can start with what does I really want to say? So less is more is one sort of fundamental principle, I think.
Yeah.
But I have some other feedback for you, because I always write down a lot of things. And I think your presentation, when it comes to interaction, you have eye contact. Sometimes you look at your own slides because you want to discuss something, but many times you're looking at the group and you have an open face, facial expression, and you have eye contact and you ask at things. So you have an interactive approach, I think, a communicative approach. You use your hands a lot. 1, 2, 3, or you show your hands would try to express or stress certain things with your hands, which is also a vivid, dynamic aspect of your presentation, I think. And you seem to me very knowledgeable. I trust what you say. You seem to know this on your 5 fingers, and you present it like that also. Some suggestions for change or for to work with is what I said about main message. You have 6 minutes, which is 1 minute too much, and at a conference this is sharp, so they might say, oh, you have to stop. So one thing to do maybe is to plan, when you find that time isn't enough, to plan an exit, like you're planning an introduction. So it's good to be prepared for what can I say finally, and how can I put that in earlier if I have to. So plan the exit. And you use rhetorical questions from time to time. Do you agree I will do this now and then I will do this in the 10 minutes? Or that's not a rhetorical question, you actually ask like that. And that's something to think about. What answer can I expect? Because if we say, no, I don't think so. I don't want you to do that on Friday. That's a quite hard a response to get.
Sure.
So maybe when you really want to be interactive but not get the answers you don't want, to be rhetorical instead. Understand what I mean? Mm-hmm. Pardon?
How should I formulate?
So you can for instance say a question like how can we start this presentation without putting everything in? That's a rhetorical question if you want that question. Or how will this procedure work? That's also a rhetorical question. And then you address the question. So that's a rhetorical question, something you address yourself.
Yeah.
And details, if you start with the first slide. Can you show me the first slide? This is really detailed, but still, I can see that you have the last names of your supervisors not in capital letters.
Yeah.
Yeah, just small things. But if you want to use this slide again, it could be good to know. I really liked you starting with the title instead of starting with your name, because I was interested in what this is about.
Yeah.
So that's one thing of one way of doing it. To start with the title or start with my name, and you decided to start with the title and explain. I also think if you show me the second slide, this you use something which is called the sequencing principle when it comes to slide design.
Okay.
So you have something you show in sequences. I think this slide is really, really good. For me it helped a lot, and it showed me what you actually wanted to talk about. So it was a good illustrative slide, I think, and the headline is really big and understandable. Yeah, I think the graphic design of your slides is mainly good. It's just, I agree with the detailing and maybe planning some slides better. But you use the colors and the size of the slides in a very good way, I think. You work with your slides. One thing you say sometimes is, I just want to, or I just wanted you to. And in Swedish we call it a diminutive, in English it's diminutive, I guess. Is that what you say in English?
Possibly.
Possibly.
We'll see where you're going
Yeah.
with it.
It means that you're trying to...
Oh, like you're diminishing what you're
Yeah,
saying.
you're
Okay.
diminishing what you're
Probably.
saying. So I just want to, or I'm going to give you a small presentation here which is just about something I do. Do you understand what I mean? And that is something to think about, to take out words that diminish your message. Because you know what you're talking about, you have the authority, I think, but when you start, I just want to show you, or I just want to. Okay, a lot of feedback from me. I just want to show you also what you can give feedback on. I don't know if you remember everything, but it was just something I thought about.
Thank you.
Interesting, I look forward to Friday.
Thank you.
Anyone who wants to add anything? Okay then. So, pass,
Let's go.
please. Let's go.